Lovely, thank you for that, Emma. So together we're just going to do a summary today of the recurring areas of transfusion and the human factors elements. We'd just like to start with an absolutely massive thank you to all the BMSs and all the laboratory staff for all the hard work that they're doing at the moment, specifically with all the extra pressures that we have and all the extra trials that are going on. And just a massive thank you for all the hard work and continuing to report during this time. So if we could just move on. Lovely, thank you. So reporting culture, we're just going to do a quick whistle stop of general short reporting this year. So we've received just over 4,000 reports this year, and that's a year-on-year increase that we're seeing, which is actually, we think, very good news, because that means that people are engaging in the short reporting and they're really wanting to learn from those errors that are occurring. So the majority of reports that we get are still near misses and no harm events like right blood right patient events. And it's really important that we continue to capture these kind of events to improve transfusion safety and that we've identified these problems before they've actually caused patient harm. So if we can move on to the next one. Thank you. Unfortunately, this year we have had 17 deaths that are attributable in some manner to the blood transfusion that a patient received, and 5 of these, unfortunately, were preventable. As normal, we see that the majority of deaths are due to transfusion-associated circulatory overload. That's a pattern that's persisting, and delays also. But what I want to draw your attention to also is the fact that, don't worry, is the fact that transfusion in itself is generally safe. Okay, so these are 17 deaths out of 4,000 reports, and that goes to a risk of about 1 in 135,000 of fatality due to blood transfusion. If we focus on the laboratory areas, thank you very much, we can see that laboratory areas are actually responsible for about 25% of all reports that SHOT receives. So that's a quarter of all the errors that we receive actually originate in the laboratory area. So we can all do a little bit ourselves now to improve transfusion practice. Lovely. Thank you. So just looking now at ABO-incompatible transfusions as a whole, so these are clinical and laboratory sources of error. They're actually equal last year. So 3 errors occurred in clinical area, 3 errors occurred in the laboratory, and they were equal split between plasma components and red cells. Oh no, sorry, I'm lying there. It was more red cells this year than plasma components, I'm thinking of last year. So when we're thinking about ABO-incompatible transfusions, these are very serious events. So the classed as never events in England, Ireland and Wales, and in Scotland they are classed as red events. And these are events that are wholly preventable. Okay, all the processes could be in place to stop these events happening. So these are ones that we can really do some key learning from. In the laboratory associated errors this year, we had 1 unit of red cells incompatible in a major hemorrhage, and also 4 units of FFP, which were administered in a major hemorrhage. So that's a key trend we're seeing there. We're also seeing trends in FFP issues in general. Okay, so the third case was group FFP transfusion group A neonate. And then you can see more detail on these in the reports and things on the website. A key, if you could just move on to the next slide. Thank you. A key part, more for your clinical colleagues, but this is our first short recommendation from the whole report. So our main recommendation is about patient identification, and we can really help with that as well. We can help with make sure our patients are identified properly within our LIMS systems, make sure all those identity details are correct on the labels, and then we can really feed in to make sure that our patients are receiving the appropriate components. Lovely, thank you. Also a recommendation for laboratory in relation to these ABO-incompatible transfusions. Our first key laboratory recommendation today is to make sure our LIMS are configured correctly and that they don't allow ABO-incompatible units to be assigned to the patient record. If that happens, then they can't then be transfused. And that's then really important in an emergency when our patient's group is unknown. Lovely. So when we look at the trends in laboratory errors for this year, the main ones that shout out at us are that handling and storage errors have really increased from last year. So they've nearly doubled. So that's the kind of events where we have cold chain errors mainly within the laboratory. So that's the first trend that we've noticed. And then the second trend that we've noticed this year is that we've had a big increase in our specific requirements not met incidents, and that's specifically testing. So if you want to just pop up the next point, the specific requirements not met are normally the largest group. So that's when people don't receive irradiated products for the laboratory. As well, it's things like incomplete testing and inappropriate electronic issue. So those are key areas that we can then be looking at within laboratory practice. Thank you. Yeah, if you just pop through the next few, I've just kind of spoken through. Lovely. Sorry, do you mind just going back to the next last one? Thank you. So our second key learning point from the laboratory is that lab staff should have the clinical knowledge of the clinical requirements. So as Dr. Booth was speaking about before, we can really help if we are a bit more aware of what's happening with our patients, and we can then help with our clinical colleagues to guide them to making those correct decisions, and then we can all help work cohesively together. Lovely, thank you. So what stage in the laboratory do we make most errors occurring? They're actually occurring most at this component labelling, availability and handling and storage step. So that's when you're attaching the label to the bag of blood, checking all your requirements that are correct, and then popping it in the fridge. And then that makes sense that that's the area where most of our errors are occurring, because that's the last process that we do. If we make an error at this point, there's no other checks that are going to capture it. Lovely, thank you. So that's why we're encouraging a bit of a stop moment at this point in time. Lovely, and if you just move it on 1 second, we've introduced this laboratory component exit check. So we don't want you to do a checklist, because I think that would take forever for every single unit, but we're just encouraging is once you've done that final labelling check, take 1 second to stop and think about all these requirements, all the details on the label. Is the component going to be stored in the right place? And then can we help expedite that process by informing our clinical colleagues? Thank you. Oh, lovely. Do you mind just popping back? Lovely. So 2 seconds on a quick case study just to do with laboratory practice this year. So this was a case from this year's report where BMS was unable to issue solvent detergent FFP to an actively bleeding patient. They were on their own during the night shift. They'd been shown the process but hadn't been fully trained in it, and the code they were putting into LIMS was creating an alert because it was the incorrect code for that group. So you can see how that's caused a real issue because of that training, and it unfortunately resulted in a 3.5-hour delay for that patient who was actively bleeding. So that's a specific example that kind of shows a trend of events that we've been seeing this year within laboratory practice. If you just move on to the next slide, please. Lovely. So we've put in a couple of key recommendations this year to do with training and competency assessment. First one is, as lone workers, you really should feel comfortable to be on shift on your own and to make sure that you've had the proper training. So we're really saying that it's the laboratory management's responsibility to ensure that staff members are properly competent before exposing them to lone working. And then when people are lone working, they should have clear, defined procedures to access specialist support. And that's actually one of the UK Transfusion Laboratory Collaborative Standards, and they're going to be updated this year. Thank you. And then the final point on the lab is well, we've kind of put this kind of guide together for what should be included in a competency assessment. I think most of it will be common sense to you guys. The key things that we wanted to highlight here is that people know the limits of the procedure, they know where to find further advice, and they know the risks of not following the process. So I apologise, that was a very whistle-stop tour of lab errors. I'm just going to pass over to Emma now, and she's going to take you through some of the human factors.
Thank you. You can just move that slide on a little bit, please. So as you, sorry, back to the next, yeah, that's it. So as you may be aware, we've been using the human factors investigation tool since 2016 at SHOT, and this is where reporters are asked to score 0 to 10 under each of the categories which are shown here. And these can be used to identify key factors when investigating incidents. And this has been a chapter in our SHOT reports for the last few years. Next slide, please. Okay, And these are our key observations. So there is evidence of attribution bias, and incident investigators should analyse all the evidence they have in front of them as impartially as possible. We are aware that this year we're introducing the concept of cognitive biases a lot more, and there is a shock bite coming out within the next week just to provide you with a further resource around that. So incident investigations need to incorporate questions using human factors principles. And there are often missed opportunities seen. So often individual staff members are scored highly when there are often other systemic causes at play. And therefore, you can move this on, staff need to be trained in human factors basics. And finally, the National Comparative Audit for Blood Transfusion has a human factors based vein-to-vein audit. And that can be focused on any part of the transfusion process. So this can be accessed by contacting them at the National Comparative Audit Office and find out how it might be tailored to build more resilient systems into your workplaces. Next slide, please. So what all this is telling us is that we need to train our staff better. So training needs to not just focus on technical training, both clinical and laboratory, but it needs to be holistic and include all 4 elements of patient safety training, human factors training, quality improvement and leadership training. And all of these things combined will provide the outcome of delivering high quality healthcare. And this leads us to the next recommendation of this year's annual report. Next slide, please. So as one of our main recommendations this year is that all staff receive holistic training that's patient-centred and includes cognitive biases and human factors training. Okay, next please. So while we're reasonably good at reporting and using data to inform improvements in practices, we often don't do enough to acknowledge continuing excellence in transfusion practices. So this year, for the first time, we've included a chapter on learning from excellent practices in our SHOT report. So this is about being curious about the realities of daily work and learning from all events and recognising and building adaptability in the healthcare system. So it's about appreciative inquiry and building resilient teams and systems. And I'd encourage you all to read that chapter and also embed learning from excellence in your practices. And I do think it's quite a refreshing chapter among all the things that we're quite often told we do wrong. Next slide, please. So when we talk about safety concepts, we talk about safety 1, which can be thought of as quite responsive, and safety 2, which can be more proactive. So reframing of safety has major implications for the way we design our systems and the role of people within them. And they can affect everything from our approaches to incidents, to quality improvement, to the way we train and lead terms. So what does it mean for teams like yourselves? How can we go about adopting it? Well, it means debriefing procedures or incidents even when they went well, not just when they went wrong. So these can be very short, they don't have to be too onerous, but ask questions such as, did everyone know what was going on? Were we clear in our roles? What hazards did we pick up and what did we miss? Were there any surprises or workarounds thrown at us? And part of making as much as possible go right means that we're more visible about the hidden work people do, and this can successfully navigate problems. And safety 2, it does also examine failures, but ask different questions to understand the actions people take. So why did that choice make sense to you at the time, and would someone else make the same choice in the same situation? So being curious like this aids learning in a way that judgment and blame never can, and it can bring about adaptability, flexibility and resilience within teams, and will have a profound positive effect on teams. So being part of a collective which supports each other and values contribution and doesn't just focus on the negative and tries to constantly improve, and that can be a really powerful antidote to the daily challenges of working within healthcare. So just in summary, that's quite a wordy slide, but it's essential to learn when things go right and not just from when they go wrong. Next, please. And this leads us nicely to our next key recommendation, that healthcare leaders should proactively seek signals for improvement from excellence in care. Next, please. So as we know, I'm sure you'll agree, that an event is not always a disaster, but not reporting one could be, and that not learning from an event is equally as bad. Next, please. So moving forward, we need to have all of these approaches. So we need to ensure good skills and experience with our staffing, use design-centered processes, clear SOPs, think about redesigning education and training, investigating incidents, learning from near misses and thinking more about systems, adjust and learning safety culture where staff feel psychologically safe and engaged, and review and share learning above all of these things. Next one, please. IT solutions should be simple and easy to use, and they mustn't increase our cognitive loads. They should be intuitive and require little or no training if that's possible. And they should be compatible with current equipment and not disrupt our workflow, and also work with every procedure as systems change across hospitals nationally and internationally. Next, please. And just to build on this, really, this is based on the WHO building blocks framework, that systems are interconnected and healthcare depends on many linked systems and factors, and it's important to remember that. So all of these factors such as leadership and governance, finance, workforce, resources, they're all interdependent on one another, and it's important that we recognise this interconnectedness of various factors in healthcare systems. Next, please. And you can see that if any of these systems go wrong, so if there's a deficiency in any of the factors, it creates a broken link. So it could be poor finances, poor staffing, and if any link is broken, it can adversely impact on patient safety. Next, please. And that leads us to our next key 2019 SHOP recommendation, and that's that healthcare management must recognise that safety and outcomes are multifaceted, and a linear view of safety doesn't fully acknowledge these interdependencies that we've talked about of resources, and healthcare leaders should ensure that all of them are in place to improve patient safety. Next, please. So just to summarise the main recommendations that we've discussed in this year's SHOP report, we have accurate patient identification, holistic training of all staff in transfusion, safety principles, including safety 1 and safety 2 approaches, and interlinked systems. Next, please. And just to finish, just to put some of what I've said into context really into your practice, we just have a short human factors case study here. So I'll just give you half a minute to read through that. But basically this was where a patient was issued and transfused platelets and red cells in separate incidents with only one group on record in the limb system. So hopefully you've had a chance to read through that rather than me talk through it all. So if we just move that slide on, please. So in the actual report, the human factors, sorry, just back. So in the actual report, the score given for individual staff culpability was actually 10, and none of the other factors were given any score at all. So basically, it was all attributed to human and staff error. However, it's unlikely that two qualified and trained and competent individuals would make related mistakes if the systems that they were using were well designed to prevent these errors. And it's interesting that the second error was actually compounded by an assumption that the required testing had been done earlier by the other BMS, and the comment highlighting that was right at the bottom of the report.
Sorry, Emma.
Yeah.
I'm not sure if everybody managed to read the...
Sorry, do you want to go back?
Yeah, maybe you can just summarize it or...
Yeah, sure. So I'll just read through it. So in the morning, a group and screen sample was processed and 1 unit of platelets was requested for the patient. The BMS realised there was no historic group on record for this patient, so added a code to the report. that stated if blood components were required, a second sample would be needed to confirm the patient's blood group. So in the early hours of the following day, a second BMS received a request for 1 unit of red cells and 1 unit of platelets. The second BMS had seen that a sample had already been received and processed earlier in the day before, and that the patient had already received a unit of platelets. So the BMS cross-matched a unit of red cells accordingly. Okay, you can move on. So as I was saying, the individual BMSs were scored 10 on that. However, there were other factors mentioned which made that seem a little bit unfair. So workload was heavy, both were lone working, and in particular the second incident occurred in the middle of a night shift. And if you just move that on slightly. Okay, and actually the corrective actions for this particular case included updating the SOP and adding a flag to the limbs. So these actions that were identified in the CAPA suggest that there were system problems that contributed to the error. And interestingly, we've seen various studies that show actual culpability by individuals expected only to be around 10%, yet it's often scored much higher in our tool. So it's likely that these higher percentages are due to a lack of awareness of system failure issues and human factors issues, which, you know, hopefully we will begin to change that and have some impact in practice. Next slide, please. So just some acknowledgement to the wider SHOT team for producing the report and these slides. And as Vicky said earlier, you as vigilant reporters and hospital staff who share your incidents with us to make these reports possible. We do have a wealth of additional resources. This year our annual report is digital. So we would encourage you please to go on that and read around these a lot more. You can order copies if necessary, and there's a slight charge for these this year. And there's a human factors video which is produced by Health Education England, and also there's a new SHOT bite coming out on cognitive bias within the next week. And also we ran our webinar when we released our report, and this was recorded, so it's available if you want to watch that retrospectively. And watch this space for further SHOT specific topic webinars as well. Thank you, that's everything. Any questions at all?